Good afternoon and nice to meet you all. Um, yes, as mentioned, my name is Dr. Simon Nothman. I'm a fertility specialist, as well as being the lead medical consultant for Genea Donor Services, so the Genea Sperm Bank, and all that goes around that. Yeah. We'll be discussing this afternoon navigating your fertility, and what we'll be talking about, broadly speaking, are fertility challenges, age, and various other factors that feed into that, egg freezing, when to seek help, various treatment options and modalities, and what's next, next steps for those who are interested in going down these pathways. So before actually talking about fertility challenges, some things that are important to be aware of and things that certainly can be done in advance for all of us include optimization of our health preconception. And this applies equally to men and to women. So first of all, recognizing any background medical conditions that need to be optimized. Checking that any medications, any regular medications that are used are safe to be used around the time of conception, the lead up to pregnancy or during pregnancy, a cervical screening test, previously or otherwise known as a pap smear, and optimizing preconception supplementation. At a very minimum, folic acid and iodine, but very commonly we would use much broader multivitamins. And again, this applies equally to male partners and not only to women. Checking infectious serology blood tests around a number of different viruses that can be of importance during pregnancy or in the lead up to fertility treatments. Thalassemia screens, being a blood disorder common in Asian and Mediterranean populations, and genetic carrier screening, in itself a very large topic, but essentially we have options of a core Medicare-funded panel, which looks at 3 genes, versus expanded panels looking at many hundreds of genes, these days between about 500 and 900 different genes. And Medicare does subsidize those to some degree, but not fully fund. Importantly, stopping ending toxic exposures, so stopping smoking or vaping. Yes, it might be slightly less toxic than smoking, but is nonetheless toxic and does have impacts both on male and female fertility. Other drugs, and minimizing alcohol intake. Optimizing BMI. BMI stands for the body mass index, which refers to essentially body weight or more appropriately body fat, which can have an impact again both on male and female fertility through a number of different mechanisms, both physical and hormonal. So what do fertility challenges look like? Infertility in general is defined as the inability of a couple to conceive a pregnancy after a year of unprotected intercourse. We add to that, obviously, while it's not, so to speak, infertility, but the challenge of perhaps being able to get pregnant, but of not being able to carry that pregnancy through to live birth, what's sometimes referred to as recurrent pregnancy loss. And these both come under the umbrella of fertility medicine. When to seek help, we'll come into some more detailed guidelines shortly, but as a very basic guide for female partners over the age of 35 who've been trying to conceive for beyond 6 months, or under the age of 35 who've been trying to conceive for over 12 months, certainly it would be worth looking into things at that point. So why is age such a big factor? Because the biology is such that actually it is. Age has a big impact on fertility and reproductive health, certainly in women and also to a degree in men, to a lesser degree, but nonetheless the biological clock does exist for men as well. And as you can see here, the chances of achieving conception, natural conception, decrease with age from at about 25% per month at age 22, not particularly high when we consider other other mammals, for example, and then declining from there over time. It's quite clear that the optimal age range in which to be building a family would seem to be through the 20s and early 30s, but obviously for societal reasons, that's not really that's not the way that things are done these days. What that does mean, though, is that it's something that we need to think about in advance. This decrease over time in fertility becomes much more rapid from the mid-30s afterwards. You can see that it falls quite rapidly from about age 36, and that relates to both a decrease in egg quantity, in egg numbers, okay, because every girl is born with all the eggs she'll ever have, and that number, unfortunately, is in decline over life, but also, at least as importantly, decreasing egg quality. And that's something that we see playing out with increased aneuploidy risk, which is to say abnormal chromosomal makeup of the embryos that are created. For example, being represented with increasing risks for Down syndrome, other chromosomal syndromes such as Klinefelter's and Turner syndrome, and increasing miscarriage risk. So not only is the likelihood of achieving pregnancy decreased over time, but also the risk of that pregnancy then miscarrying also increases exponentially with increasing age. So what are some of the factors that affect fertility? The split overall is essentially that there's only one bullet point that relates to male factor infertility. Actually, it contributes to about half of couples who have difficulty achieving pregnancy. And that can relate to a number of different problems with regards to sperm production and sperm quality. On the female side, it can relate to irregular ovulation or not ovulating at all, such as in polycystic ovarian syndrome, advancing maternal age and egg quality, which can also come with problems with ovulation, endometriosis being a disease which can result in scarring around the fallopian tubes, blocking passage of the fallopian tubes, as well as impacting egg quality and embryo quality. Blocked tubes for other reasons, for example, subsequent to surgeries or infections within the pelvis. Sexual dysfunction, obviously, or difficulty being able to time sex at the right time of the period around the ovulatory window can present difficulties achieving fertility, and also what's referred to as unexplained infertility, in which about 15 to 20% of couples who have difficulty achieving pregnancy don't have any obvious defined reason for why. And that can be in itself quite a challenging situation to be in, not to know what's underlying the infertility, both for the couple and for the doctors and the treating team. So lifestyle factors are something that I'm quite passionate about, and something that I discuss with all of my patients in our one-on-one consultations or two-on-one consultations. And lifestyle factors can have a big impact both on male and female fertility. It does this through affecting hormone levels, as well as altering or creating a more inflammatory environment. And this relates to toxin exposures, primarily smoking, other drugs, also alcohol. Caffeine, if taken in excessive quantities, up to a couple of cups a day is fine. Nutrition and weight obviously can also have important impacts, and stress is a challenging factor to really measure or study in an objective fashion, but does seem to correlate with fertility problems as well. So let's discuss egg freezing. As we've mentioned, age has a very significant impact both on the number of eggs and the quality of those eggs. And as a result, many women are choosing to freeze their eggs because they're aware of the impact of that age. It's something that has not always been an option, but has become much more common, much more prominent in the last 5 to 10 years, and now is considered to be a routine and very high potential route of treatment for women who are thinking or planning to delay their fertility. It's a fairly straightforward process. There are some standard pre-treatment investigations that we would want to perform, both as baseline assessments, but also to give us a tool to assess the likely number of eggs that we might be able to retrieve in a given patient, which is quite variable from woman to woman, and that helps us gauge our sites, the number of eggs we think we're likely to want based on her family plan. Or desires, and with that, an idea of how many cycles she might likely need to undertake to be able to build those sorts of stocks, the numbers of eggs that would give her a good chance of building the future family that she desires. We undertake egg stimulation, very similar to what we would do in IVF, and egg collection likewise, and we will discuss these a little bit further down the line when we're talking about different treatment modalities. These eggs are not fertilized, but rather are frozen and stored as is and remain in the state and retain the qualities that they had at that time. That is to say, a woman who undertakes egg freezing at, say, age 32, even if she uses them at age 42, those eggs will retain the qualities and the risk or lower risk for miscarriage, aneuploidy, etc., as they would at age 32, regardless of what age it is that she ends up using them. So when to seek help? We mentioned before that we have this general guideline of women under the age of 35 should be trying to conceive for 12 months, and over the age of 35 are trying to conceive for 6 months. But this is based on a sort of a presupposition that everything can work as it should. If we know or suspect of any underlying condition that may have an impact on fertility, or any situation, not necessarily a medical condition, but one that would preclude natural fertility, then obviously that general rule doesn't actually apply. So bullet point number 2 here, for example, women who have polycystic ovarian syndrome and don't ovulate on a regular basis, or those who are known or suspected to have endometriosis, would certainly be well advised to seek testing and assistance if required at a much earlier stage, rather than waiting for months of frustration, only then to discover that actually they do need assistance and the situation has deteriorated over time. Recurrent miscarriage, obviously, while it's not infertility per se, as they have been able to conceive, nonetheless, it is a significant obstacle to actually building a family, and would be well advised to seek an opinion. Known or suspected genetic conditions, so people who have a family history of genetic conditions, or who, for one reason or another, have undertaken genetic testing, as is performed in some ethnic communities, for example, or just for whatever reason, because of work-related insurance. If those are discovered, they can also potentially have an impact on one's fertility future, for example, through the option of undertaking genetic testing on embryos to filter out those genetically abnormal embryos, or those that would be at risk for having a genetic disease. Again, if you've discussed conception with your GP, undertaken testing, and still have not achieved pregnancy, even though there's no obvious diagnosis, by all means seek help. Likewise, regarding fertility preservation, as discussed, that applies both to men and to women. Much more common these days for women, but nonetheless it's a very simple procedure to freeze sperm, and is an option for men as well. And obviously for those who belong to the LGBTQ community, for whom natural conception is not really a feasible option, and they would want to discuss the options that do exist for those populations in those situations, definitely should be seeing a fertility specialist. And likewise, for those who have decided to become a parent with the assistance of donor eggs or sperm or embryos should see a fertility specialist sooner rather than later. So what are the treatment options? There are a number of different modalities that we can employ in fertility medicine to try to help people build their families. The kind of most famous these days is IVF, in vitro fertilization, which simply refers to taking the fertilization process outside of the human body and performing it in the lab. And there's a bit of a subset of that, and we'll look at the difference in a little bit. We have ICSI, which stands for intracytoplasmic sperm injection, in which we inject the sperm cell into the egg itself. But in terms of much more basic therapeutic options, we start from ovulation tracking. For those for whom that would be helpful and gives them data where there's no other barrier that would seem to be obvious, and Genea does provide a bulk billed ovulation tracking service for up to 3 cycles. Ovulation induction is something that we do primarily in women who don't ovulate on a regular basis, and that can be done to be used with intercourse, just with sex, or can be done together with IUI, intrauterine insemination, in which a semen sample is prepared, spun down and concentrated, hopefully selecting the best of the batch, and injected into the uterus through a fine catheter at the time of ovulation. Pre-implantation genetic testing, as I've referred, can be done for testing for specific mutations, particular known genetic abnormalities that we want to weed out, and likewise for aneuploidy, for abnormal chromosome numbers, removing from the pool of embryos that we have at our disposal those that would seem to have Down syndrome or other chromosomal abnormalities that would result in unwell children, as well as removing those embryos that we expect would result in miscarriage. So reducing the risk of miscarriage and shortening the timeline to a successful pregnancy. Egg or embryo freezing, as noted, and likewise use of egg or sperm donor services and surrogacy. So ovulation induction, as we've mentioned, is about inducing ovulation in women who don't ovulate on a regular basis. It is primarily useful in younger women, those below the age of 35, where the only problem relates to a lack of ovulation. In older women who have a lower chance of pregnancy, or when in combination with some sperm factor, for example, or blocked tubes, it's much less likely to achieve the desired result, and so other options would be generally more appropriate. There is an increased risk of multiple pregnancy because, unlike IVF, where we can select the number of embryos that we are trying to implant, ordinarily 1, here we're essentially letting millions of sperm cells go at the time of ovulation, and if we have inadvertently, knowingly or unknowingly, achieved ovulation of multiple follicles, then that comes with obviously an increased risk of multiple gestation, which is a high risk pregnancy, high risk for every pregnancy complication, but particularly for preterm birth and the complications of prematurity that result from that. Assisted insemination, IUI, as we mentioned, is simply the placement of sperm inside the uterus at the time of ovulation. This is done through a fine catheter, as you can see on screen, a simple gynecological examination with a speculum, similar to a pap smear, for example, and the insertion of this catheter, ordinarily not painful, obviously a gynecological examination, so not the most pleasant experience in the world, but usually not an overly painful experience. And IVF. So IVF is a much more successful, but also somewhat more technical and demanding process on a technical level. It involves a number of stages, both stimulating the ovaries and essentially that is to increase the yield and the efficiency of the process, so that we can not make use of one egg that ovulates on a monthly basis, but rather of the whole cohort, hopefully, of eggs that have developed up to that stage of development and are able to be accessed for our purposes. Collection of the eggs and sperm. Okay, we do that on the same day. Fertilizing the embryos in the lab and monitoring them over the coming days. Transferring the embryo into the uterus. Ordinarily, that would be done 5 days after after egg collection and embryo creation, but also can be done with frozen embryos subsequently. And luteal phase support, followed by the pregnancy test. So ovulation induction, ovulation stimulation, or ovarian stimulation. On the left, we can see an ovary with one large follicle and a few smaller follicles, and that is what an ovary would generally look like in a natural cycle, where one follicle develops and essentially results in the suppression or even killing off of its neighbor follicles, and that one follicle develops and then ovulates. That is unfortunately an inefficient process. And so when we're going through the process of IVF, so as to make it a much more efficient process, both efficient in kind of financial and effort terms, but more importantly, to make the most of it and to be able to develop as many embryos as possible and to be able to select from them the best for building your family. We want to stimulate the ovaries to get as many eggs as possible effectively. And this on the right is what a stimulated ovary looks like, with multiple follicles that have responded to the stimulation and should hopefully contain mature eggs. Egg pickup or egg collection is a procedure, and essentially is the invasive procedure that is associated with IVF and is the main medical procedure in this sort of treatment. It's a brief procedure, about 15 minutes, can be done under general anesthesia or local anesthesia with light sedation. And essentially it's an ultrasound-guided needle biopsy, which is to say that we use a vaginal ultrasound, the same as a regular vaginal ultrasound that would be used in diagnostic testing, routine examinations, etc. And attached to that ultrasound probe, we have a fine needle, as you can see in the diagram, which we insert through the upper vaginal wall, directly into the ovary, into each of the follicles, and extract the fluid from each follicle, and with the fluid, the egg as well. The egg is a microscopic structure. We can't see it with the naked eye, and we can't see it on ultrasound either. The follicles are our proxy for the egg, but not every follicle does contain an egg, and we know that with increasing age, the proportion of follicles that do not contain eggs and do not contain viable eggs does increase. So this is an invasive procedure, but not an operation per se. There are certainly no scalpels involved, no abdominal incisions, but does carry with it a very small risk of bleeding or infection, well under 1%, and usually well, we would know in real time how many eggs we've retrieved. We have a scientist, an embryologist in the room with us, filtering through the follicular fluid and in real time reporting on the number of eggs that we have. So as soon as you are out of the procedure, certainly as soon as you've woken up from the anesthesia, for those who prefer that option, you would already know how many eggs we have. At the same time that we are collecting the eggs, the male partner, in the event that there is one, will be off preparing a semen sample, and both the eggs and the sperm are taken into the clinics, into the lab for fertilization. All of our clinics have really comfortable facilities for producing a semen sample. We recognize that can be a sensitive point for men involved in this process, and we really have made efforts to make sure that we have comfortable and sensitive areas for them to be able to do that in privacy. So in the lab, we take the sperm, we take the eggs, and we hopefully get them to collaborate together. So at the beginning, on day 0, that's the day of egg collection. This is what it looks like on the left here. In IVF, we have the egg surrounded by its kind of protective cells and a whole lot of sperm together. The embryologists will speak to you both before and after the procedure, and certainly in the following few days as we're watching the embryos develop. Next slide, Bear. So, as referenced before, there's a slight difference between a couple of different methods that we have for achieving fertilization. IVF, in vitro fertilization, is the classic procedure in which an egg is bathed in a petri dish surrounded by many thousands of sperm cells. Those sperm cells kind of work together to try to dig through the layer around the egg, and then one of those actually pierces through the egg to fertilize it. In ICSI, we select a sperm cell and inject it with a very, very fine needle directly into an egg that's had its outer layer removed already. And this is usually something that is done in severe male factor situations, but there are other circumstances in which we may choose to undertake ICSI rather than IVF for improving fertilization statistics or embryo outcomes, if it's thought that will contribute. Thanks, Bear. So so this essentially says what I've just said. These fertilized eggs go into a specialized unit and are followed up there over the coming days. We watch them develop. We get an update on day 1, day 3, and day 5 and 6. So at day 1, we can see a very basic preliminary assessment of fertilization. So in this embryo here, or it's not yet an embryo, a fertilized egg, we can see what's called 2 pronucleae, those things in the center, and that's an indication of normal fertilization. We will also see sometimes we'll see abnormal fertilizations, and we might find eggs that have failed to fertilize. While we don't get a day 2 check, this is what they would look like. Okay, doubling at this point with about 4 cells. Day 3, we get our update. Generally speaking, something in the realm of 6 to 10 cells would be standard, and then continuing to track them out over the next few days. Our standard is for embryo transfer on day 5, and Genea was actually one of the first fertility groups in the world to make that standard. And we've been able to do that, aside from anything else, through the development of the Jerry time-lapse incubator, which was a Genea invention. And what this allows is for, as you can see, there are separate compartments here, and essentially each patient has their own compartment. Their eggs and sperm, their embryos are in there, and they're monitored continuously, and they're not disturbed. So in the past, what was done is that fertilization would be performed, and eggs would the fertilized eggs, the embryos, would be taken out on a daily basis, or occasionally even more frequently than that, to be checked on. This time-lapse incubator with a built-in camera allows us to keep them in a safe and monitored environment, checking temperature, checking levels of gases and all the different components that the eggs need to be able to develop appropriately, the embryos, and being able to monitor them without disturbing them. And this is one of the components, one of the aspects that gives Genea the leading edge and the leading outcome statistics as well. And through the use, or I guess as a byproduct of the use of these Jerry incubators, you also get updates with regards to your embryos. Not only a call from the embryologist, but also being able to see them, and you'll get photos on your phone through the Grow app of what they look like at each of those checkpoints, day 1, day 3, and then 5 and 6. So you have images of your embryos, and just anecdotally, a lot of people really get quite attached to the embryos that they've seen developing over the days, and it's really quite lovely for them as well as for us, to then be transferring an embryo that isn't just a kind of a theoretical thing that you've been told about, but is something that you've actually watched growing over those previous days. So embryo transfer is, for the most part, a relatively straightforward process. Obviously, it's something that needs to be done with care and accuracy, but for the most part, a fairly straightforward process. Similar to IUI, it involves a speculum examination and insertion of an embryo transfer catheter. Because of the desire to do it kind of more accurately, it is done under ultrasound guidance, so with an abdominal ultrasound, confirming the placement of the catheter, confirming the depth of the catheter within the uterine cavity, and you can see this all happening. You see a bit of a white flush as the embryo and the fluid around it is injected into the uterus. And this is something for which the patient, the partners, would also be present, and other than in very uncommon circumstances, is awake. Doesn't involve sedation or anesthesia. So something that patients really do take part in to a full degree, and really get quite emotional about being part of. Following also prior to embryo transfer, but continuing beyond embryo transfer and through to the pregnancy test and often beyond, we give supportive medication, what's referred to as luteal phase support, and that's essentially additional progesterone medication. Progesterone is the hormone that is naturally secreted by the ovaries to support implantation and support early pregnancy development. In the context of IVF, we would ordinarily add some progesterone to the naturally secreted progesterone. We can sometimes use HCG or other medications as well as part of these sort of regimens, but that's something that would be personalized based on your doctor's assessment and what would seem to be the most appropriate in your particular circumstances. We continue that out at least to the pregnancy blood test, and if that's positive, when that's positive, depending on the protocol, that may be continued beyond as well, or may be ceased. As part of an IVF cycle, Genea does offer support, including during what's referred to as the 2-week wait, because that can, for many patients, be actually the most challenging, most stressful part of the process, the wait, rather than the treatment itself. So for many patients, certainly those in the LGBTQ community, but also some who decide to go through the process of lone pregnancy, or some couples for whom it's required, donor sperm, donor eggs, and surrogacy are important options for them, and in some cases maybe the only route to biological family building. And Genea offers a range of pathways to do this. We have a very experienced donor team, a a growing sperm bank as well as links with international sperm banks. So no shortage of options for those who desire donor sperm, donor eggs, um, and we would be able to facilitate these things for you as required. It does require assessment through a fertility specialist, because at the end of the day, we do need to check that there aren't other potential issues that need to be considered in part of this, and what sort of sperm would be appropriate, or eggs, for example, for a particular situation. But yes, and it is a bit of a process, and we have very experienced teams to assist you with it. IVF and fertility medicine, as I see it, is the ultimate team sport in medicine, and really involves a huge number of different people, all there to support you. So aside from the fertility specialists themselves, we have large numbers of nurses working in different teams and different roles, who will be in contact with you throughout the process. Andrologists, those who deal with sperm, particularly where there's some degree of male factor infertility, but regardless, will always obviously need to be involved to some degree, other than for egg freezing. Counsellors, as mentioned, have a very important role in the fertility journey and fertility treatment, and we have a great team of counsellors at Genea that, if required, I hope you're able to take advantage of. Genetic counsellors and geneticists, as required, if there is some underlying genetic condition that needs to be addressed and thought about. Patient care coordinators, likewise, taking you through the process from before the beginning through to the end. Embryologists, who are the ones that make the magic happen in the lab, and assist us with embryo transfer, and obviously from your side, the ability to continue to be in touch through ongoing communications through the MyGenea and the Grow apps, making this a seamless process as possible.